Welcome to the all viewers and well wishers of the world. The purpose of my lecture is learn the knowledge from the world and return the knowledge to the world. Motto of my life is learn, earn and return. I have learned a lot, earned a lot, now to return a lot to the world. Topic of today is neonatal jaundice. As one can see, the kid which have been born, healthy baby, and there is no jaundice there, but here one can see the baby with yellow skin, and that is the baby with the jaundice. And here again one can see the normal color of the skin of the baby, and here the jaundiced skin of the baby, that is yellow. Now, neonatal jaundice is the medical term for the jaundice in the newborn babies. Other names are neonatal hyperbilirubinemia, neonatal icterus, or jaundice in the newborns. It is common and usually harmless. Symptoms are yellowish discoloration of the skin and the white part of the eyes, that is the sclera, in the newborn due to the high bilirubin level that is called hyperbilirubinemia. A bilirubin level more than 2 milligram per deciliter is visible to the naked eye by the physician, and physician can have the suspicion of neonatal jaundice. Here levels are greater than 18 milligram per deciliter, which is very obvious from the skin and the sclera of the patient. Baby is examined for signs of the jaundice within 72 hours of being born, and yellowing of the skin is difficult to see in brown or black skin, but it is easier to see on the palms of the hand or the soles of the feet in those cases. Complications are seizures, cerebral palsy, and kernicterus if the treatment is not offered right in time. Types are physiologic and pathologic. Causes are red blood cell breakdown, liver disease, infection, hypothyroidism, metabolic disorders, and jaundice seen in first day of life with rapid rise in the levels. Jaundice lasts more than 2 weeks, so that gives suspicion of neonatal jaundice. If baby develops signs of jaundice after this time, get advice of the doctor. There could be some other reason of the jaundice besides the physiological, or which is usually called neonatal jaundice. If baby symptoms get worse or the child is reluctant to feed, that is a matter of worry, and one should contact the doctor for that. Diagnostic methods are based on the symptoms, and that is confirmed by the bilirubin level in the blood by the blood sample. So, do further investigation to determine the underlying cause of the jaundice besides this physiological jaundice. Treatment is more frequent feeding, phototherapy, and exchange transfusion. Frequency is about 50% of the babies suffer this problem. Now, epidemiology. Jaundice is one of the most common conditions that affect newborn babies. 6 out of every 10 babies develop this physiological jaundice, including 8 out of the 10 babies born prematurely before 37 weeks of the pregnancy. They are also prone to have this problem. Only 1 in 20 babies has a very high blood bilirubin level to need treatment. Otherwise, it can lead to the kernicterus, means the bilirubin has got entry into the central nervous system. Now, types of the physiological jaundice or the neonatal jaundice, rather, they are mainly of the two types, physiologic and pathologic. In most cases, there is no specific underlying disorder, so that is called physiologic jaundice. And physiologic jaundice lasts less than 7 days and it disappears automatically. If the cause is red blood cell breakdown, liver disease, infection, hypothyroidism, or the metabolic disorder, we label it as pathologic jaundice. Of babies that are born early, about 80% are affected, means premature are more prone to have this problem. Now, physiological jaundice, most infants develop jaundice due to the increased unconjugated bilirubin level in the first week. This hyperbilirubinemia has two functionally distinct periods. In the phase 1, the full-term infants jaundice lasts for 10 days with a rapid rise of the serum bilirubin up to the level of 12 milligram per deciliter. And in preterm infants, the jaundice lasts for 2 weeks with a rapid rise of the serum bilirubin that is up to the 15 milligram per deciliter or 15 milligram percent. In phase 2, bilirubin level decline to 2 milligram for 2 weeks, mimicking the adult values. And in case of preterm infants, it lasts more than 1 month to come down. Exclusively breastfed infants, it can last more than 1 month. Now, what are the mechanisms involved in the physiological jaundice? Low activity of the enzyme glucuronyl transferase, which converts the unconjugated bilirubin to the conjugated bilirubin. So this enzyme activity is low. So that is excreted into the gastrointestinal tract. Before birth, this enzyme is well functional as the bilirubin had to remain unconjugated to cross the placenta and not accumulate in fetus, and the child is using the liver of the mother. Now, after birth, this enzyme takes some time to become well functional in the babies. Shorter lifespan of the fetal red blood cells, which is about 80 to 90 days as compared to the 100 to 120 days in case of adults. So, low conversion of the bilirubin to urobilinogen by intestinal flora, so high absorption of the bilirubin back into the circulation and causing the hyperbilirubinemia. Body is not able to get rid of the bilirubin normally as in case of the adult. So that is why the bilirubin do accumulates in the baby and causing hyperbilirubinemia and neonatal jaundice. Now, one can see the liver which contain these enzymes UDP, glucuronyl transferase, and that is just responsible for transferring and transforming unconjugated bilirubin to the conjugated bilirubin, and this conjugated bilirubin is excreted through the bile, and this conjugated bilirubin that is just by the microbial breakdown that is released into the stool via the defecation, and the sum of the conjugated bilirubin that is just going to become unconjugated bilirubin again, and that is not going to be excreted in the feces, and this deconjugation lead to the reabsorption of the bilirubin through the blood vessel, and this all is absorption through the blood vessel when the liver is not able to excrete and deconjugate the bilirubin properly and not to excrete in the feces. So this all is called enterohepatic circulation. Entero mean intestine, hepatic mean. So through the intestine, there is reabsorption of the unconjugated bilirubin, raising the level of the bilirubin in the blood, causing hyperbilirubinemia. The status of the son was made with pieces removed from the status of the father, representing the parents what they do and go through their life to build the lives of their children. One can see the hole in the body of the father, and these holes, the material taken it from these holes are going to fill the holes in the son. It is only the father which want to see his son better than and further risen than his father. Now, pathological jaundice. Any of the following features suggest pathological jaundice. Clinical jaundice appearing in the first 24 hours or greater than 14 days of life, it remains there and does not subside in 7 days as in case of physiological jaundice. Increase in the level of the total bilirubin by more than 5 milligram per deciliter per 24 hour, and the total bilirubin more than 19.5 milligram per deciliter, that is labeled as hyperbilirubinemia. Direct bilirubin more than 2.0 milligram per deciliter, and the signs seen in the pathological jaundice are presence of intrauterine growth restriction. Stigma of the intrauterine infection are the cataract, small head of the baby, and the enlargement of the liver and spleen, that is called hepatosplenomegaly. Now, cephal hematoma, bruising, signs of the bleeding in the brain ventricle is seen. The level is more of bilirubin. History of the illness important. Family history of the jaundice and the anemia is there. Family history of the neonatal or early infant death due to the liver disease is also noted. Maternal illness like viral infection, fever, rash or lymphadenopathy, and maternal drugs used during the pregnancy like sulfonamides, anti-malarial drugs causing red blood cell destruction in G6PD deficiency, and also glucose G-phosphate dehydrogenase G6PD and inherited enzyme deficiency lead to the jaundice or kernicterus. Family history of this problem is there, and all these are responsible for causing pathological jaundice. Now, here one can see the breakdown of the hemoglobin and the other heme proteins that is going to make unconjugated bilirubin, and that is bound to the albumin. When it reaches to the liver, in the liver it is being conjugated, and that is by the glucuronide transferase. I have already told you in the previous slide, and this conjugation is responsible for excreting this bilirubin through the bile into the intestine, and it is excretion through the bile duct into the intestine. From the intestine, some of the bilirubin is going to change by the bacterial intestinal flora in the colon to the stercobilinogen, and that is excreted in the stool to get rid of the excess bilirubin. But some of the bilirubin that is being reabsorbed via the enterohepatic circulation, and that is being entering into the blood, causing the increase in bilirubin level. Some of the bilirubin, when it get entered into the blood, that is also excreted through the kidneys as urobilinogen to just give relief to some of the high bilirubin in the blood. Now, an underactive thyroid gland, hypothyroidism, thyroid gland is not producing enough hormones, blood group of the mother and the baby incompatible, mixed during pregnancy or at birth. Rhesus disease, mother has rhesus negative blood and the baby have rhesus positive blood, that also cause this pathological jaundice. Then urinary tract infection, Crigler-Najjar syndrome, an inherited condition with defective enzyme which process the bilirubin, so the bilirubin is not processed well, and as it is being absorbed into the blood causing the hyperbilirubin. Then blockage and the problem in the bile ducts and the gallbladder, so the excretion into the intestine via the bile duct is impaired and leading to the high level of bilirubin. As gallbladder stores bile, bile duct transport the bile to the gut. If there will be any blockage and problem there, that is going to cause the hyperbilirubinemia. So here one can see the pathological jaundice as unconjugated bilirubin, which is called indirect, that is due to the hemolytic causes or the non-hemolytic causes. And then conjugated bilirubin, which is causing the pathological jaundice, that is because of the defect in the liver. So there are hepatic causes and the defect after the liver, these are called the post-hepatic causes. Now, one can just have the difference of the pathological jaundice and physiological jaundice. In case of the physiological jaundice, it never appear in first 24 hours and pathological jaundice appear in first 24 hours. In physiological jaundice does not stain palms and soles, but in pathological jaundice it stain palms and soles. In physiological jaundice, urine does not stain diapers, always unconjugated bilirubin is there, but there is pathological jaundice, high colored urine and clay colored stool are present. And in case of physiological jaundice, it does not persist beyond 3 weeks, may persist beyond 3 weeks sometime, but pathological jaundice always persists beyond 3 weeks. So these are the differences between the two, physiological and pathological. Now, coming to the causes of this neonatal jaundice, reasons unclear. Jaundice is caused by the buildup of the bilirubin in the blood. I have already told you the reason. Bilirubin is a yellow substance produced when red blood cells are broken down. Babies have a high number of red blood cells in their blood. Newborn baby liver is not fully developed, so less effective at removing the bilirubin from the blood. And I have already told you that when the baby is 2 weeks old, liver now is more effective to process the bilirubin, so the jaundice corrects itself without causing any harm. The liver is capable of excreting the bilirubin through the bile, and the intestines are going to get rid of the bile through the stercobilinogen, and the kidneys are also going to release the bilirubin as urobilinogen. Now, the bilirubin travels in the bloodstream to the liver. The liver changes form of the bilirubin so it can be passed out of the body in feces. I have already told you that. So here one can see the red cell destruction, heme proteins, and the bone marrow erythropoiesis. All these are responsible for producing the bilirubin that is circulating by attaching with the albumin, and this bilirubin is unconjugated, and when it reaches to the liver conjugates this bilirubin, and through the bile duct it is going to just release this bile carrying the bilirubin into the intestine, and from the intestine the bacterial deconjugation lead to the fecal stercobilinogen, that is to get rid of the bilirubin from the body. And also from the liver, some of the bilirubin is being absorbed by the blood, and when this blood comes to the kidney also get release of this bilirubin as urobilinogen. Now, if there is too much bilirubin in blood, liver cannot get rid of it as it is not well formed liver in case of the newborn, and excess bilirubin causes jaundice. Breakdown of the fetal hemoglobin replaced with the adult hemoglobin that also solves the problem. Immature metabolic pathway of the liver unable to conjugate and quickly excrete bilirubin like adult is also one of the cause. This causes an accumulation of the bilirubin in the blood causing hyperbilirubinemia and the jaundice. Consider the causes like biliary atresia, progressive familial intrahepatic cholestasis. I have already told you the defects in the gallbladder and the bile ducts also responsible for not getting out the bilirubin and excreting into the intestine. Bile duct paucity, Ala-Gili syndrome, alpha-1 antitrypsin deficiency, and other pediatric liver diseases are responsible for this neonatal jaundice. Now, the breastfeeding, there is breastfeeding jaundice or breast milk jaundice by insufficient breast milk intake, so less bowel movement to remove the bilirubin from the body as there is stasis of the bilirubin in the intestine. This leads to the increased enterohepatic circulation resulting in increased reabsorption of the bilirubin from the intestine, also due to the increased level of epidermal growth factor EGF in the breast milk. Breast milk also contains glucuronidase, which will increase deconjugation and enterohepatic circulation of the bilirubin. Usually it is seen in the first week of life. An enzyme in the breast milk called lipoprotein lipase produces increased concentration of the non-esterified free fatty acid that inhibit the hepatic glucuronide transferase enzyme, so decreased conjugation and the excretion of the bilirubin and the accumulation of the bilirubin in the blood. It is unclear why breastfed babies are more likely to develop jaundice, but certain theories are there. Breast milk contains certain substances that reduced ability of the liver to process the bilirubin properly. Higher bilirubin possibly act as an antioxidant, and the breastfeeding jaundice is a mechanical problem, a biochemical occurrence for neonatal jaundice. Now, breastfeeding jaundice occurs late in the newborn period with bilirubin level peaking in 6th to 14th days of the life. This late onset jaundice develops in 33% of the healthy breastfed infants. The gut is sterile at birth and normal gut flora takes time to establish to cause the get release and get rid of the bilirubin as it is in case of adults. So gut which converts conjugated bilirubin to stercobilinogen then oxidized to the stercobilin and excreted in stool is hampered. If bacteria are not sufficient, bilirubin is deconjugated by the brush border beta glucuronidase and reabsorbed in the blood. So here one can also see the senescent red blood cells, the old red blood cells, hemoglobin, and that is going to change to the biliverdin enter into the blood, thus combined with the free plasma protein and then enters into the liver. The conjugation, from the conjugation, it just release the bilirubin via the bile into the bile duct and when it is in the intestine, the bacterial flora that is just going to cause the breakdown of these bilirubin, and then it is going to enter through the feces and get rid from the body, and when it is going to enter the general circulation through the kidney, it is excreted in the urine as urobilinogen.